Welcome to the Rural American Surgeon. I'm your host, Dr. Randy Lehman, a general surgeon from Indiana. This show is tailored around the nuts and bolts of rural general surgery practice. You will find topics such as practical surgical tips, rural lifestyle, finance, training, practice models, and more. We have a segment called Classic Rural Surgery Stories, where you'll get a feel for how practice in the country differs from the city. If rural surgery is your passion, this show is for you. So, now that the ChloraPrep has dried, let's make our incision.
Welcome back, listener, to the Rural American Surgeon Podcast. I'm your host, Dr. Randy Lehman, and I have with me today special guest, Dr. Mel Johnson. She is the new president just elected of the North American Rural Surgical Society. She's also program director at Gundersen Lutheran, which is in La Crosse, Wisconsin, and has a history of training rural surgeons. And she has a special passion and interest, and I'm so honored to have you on. Thank you so much for joining us, Dr. Johnson.
Thank you so much, Dr. Lehman, for the invitation to be on your podcast. I am absolutely passionate about training individuals to become rural surgeons. And so this is an absolute privilege for me to be on your podcast today.
Yes, thank you for being here. So you trained at South Dakota and then went to medical school at South Dakota, then went to Rush, and then you ended up back in the role that you're in. Could you tell us a little bit about that journey?
Absolutely. I am a South Dakota native, so born and raised in Sioux Falls, South Dakota. So when I decided to go to medical school, I did go to the University of South Dakota. I was mentored very much by a gentleman who was a rural surgeon for years, and ended up going to Rush and Cook County Hospital in Chicago for my residency training, which that may sound like that's not very rural, but 50% of our training was at Cook County Hospital, which is working with very much underserved population, people oftentimes with advanced disease because they haven't had access to healthcare. So I really feel like he felt like that would train me perfectly for, again, treating the underserved of America, and that absolutely did. I returned to South Dakota upon my graduation from residency and practiced in Sioux Falls, both at Sanford and the VA hospital, and helped start the surgical residency program there. And then just 5 years ago, Gundersen had reached out to me and said, hey, will you come take a look at our program? And I made the move over to Gundersen and then took over 2 years ago as the program director of the residency program. So that's sort of how I ended up from South Dakota over to Crosse, Wisconsin.
Yeah. And then, of course, we just elected you in January to North American as our president, and we just are so glad to have you as our representative. And the other thing that I, wanted to touch on was that Dr. Timmerman that was mentoring you or somebody?
That is correct. Yep. He is my surgical mentor.
We're working on getting him on the show as well. Obviously just a giant in rural surgery. And the other thing I wanted to mention is I totally agree with you that a training for a rural surgeon doesn't mean that you spend 5 years in a critical access hospital. That would be terrible training. Matter of fact, I was on like a focus group or something like that. I use working in Indiana on potentially making a 1 year fellowship after residency for rural surgery. That's sort of at the moment is paused for financial reasons. But that was one of my big things I kept repeating is, they can come rotate with me in the critical access setting, but like if you want them to be able to do hysterectomies, like they shouldn't come do maybe one in a month with me. They should go to an OBGYN or that sort of thing. You need to be in a high volume center, high acuity center, and also because you're the surgical gatekeeper for your community later. So to know when you're sending, what they can do, and go to Mayo, for example, and now I can see the intraoperative radiation that they're doing and, crazy stuff that's like out of the box, and who needs to be on a clinical trial and stuff like that. So Thanks for kind of commenting on that.
Yeah, absolutely. I think, when I reflect on my training, again, being in a higher acuity, very high volume setting, but I also was in a setting, especially at Cook County, it was for financial reasons. We oftentimes did not have all the resources that we would have wanted. And so it also trained me to think outside the box. It was nice. I had both settings. Rush had everything. Cook County had very little. But it sets you up even to be in a rural setting whereby you may not have the mesh that you want, in any given case or whatever that may be. And it teaches you, okay, there's 10 different ways I could do this. So what do we have today? And all right, we're going to go forward with that. So again, I think, and I love too that you mentioned that IU is looking at doing a 6th year. You've got to ask Gary Timmerman about this in the future when he's on your podcast.
I know.
Because he's a huge believer in the College of Surgeons Fix the 5. Really is why we started the surgical residency program in South Dakota, was starting a 5-year program whereby people come out ready to do everything that you need to do as a rural surgeon. So he's a huge believer in we should be able to get people out in 5 years.
I'm a believer in that too, but if it's not doing it, and having multiple tracks is not necessarily wrong. I could riff off of this all day long, but one more thought I had is if you get a chance as a trainee to go do international surgery, that's another way that you can sort of put yourself in that resource limited situation. And all of a sudden you're starting to think, oh, wow, what of these things is actually essential that I have at the ivory tower and what is not, Right. But perhaps we move on to the next segment of the show. Why is rural surgery special to you? I mean, I know you're born and raised in South Dakota.
Yep. That really was what started it, is seeing, going through med school and seeing how many of our patients spread throughout the state, especially the rural areas, did not have great access to care. Particularly practicing there after being at Cook County for trauma. I used to practice trauma surgery too when I first got out. And to see that in Chicago, everyone's within 10 minutes of a level 1 trauma center. In South Dakota, I was taking patients from Pine Ridge Native American Reservation, which is out by Rapid City, and the average transport time was 12 hours. So just seeing death that results, death and disability that result from really just geographic isolation. So that was, I would say, where it started, is early in my practice, and seeing just how distance keeps people from accessing care. And then starting a residency program at USD that was focused purely on producing broad spectrum general surgeons. And then it's just even deepened with going over to Gundersen. Gundersen's been doing that for more than 60 years, really focusing heavily on producing general surgeons, many of whom go into rural practice. And here I've just got to put in a little plug. Our program produces 2/3 practicing general surgeons and 1/3 people that go into fellowship. And if you look at national statistics, 80 to 90% of people in general surgery residency programs go on to fellowship. 1/3 of ours go on to fellowship. Out of our 2/3 that practice general surgery, half of those go into what would be an urban practice, which means greater than 50,000. The other half are practicing in a place that's less than 50,000. And so again, that really led me in going there, because again, that's what they've been doing for years. That's what we continue to try to do, because when you look at the shortages in the nation, that's where we need surgeons. We don't need more urban, academic, subspecialized surgeons. We need people out there caring for people as broad spectrum general surgeons.
Could not agree more. I have a couple of specific questions to answer to your comfort level about Gundersen. So they just had a big Bellin merger.
Correct. Mm-hmm.
Is that going to affect your residency program? Is there a different name now to your residency program?
Great question. Because if you look us up online, you'll see this word Amplify. So Amplify is the name that they have given to the two of us together. So Gundersen's been around forever. Bellin out in Green Bay has been around forever. Bellin does not have a surgical residency program, nor do they have plans to have one. Gundersen has had one for decades, and we will continue to have that. So the merger was really more of expanding our footprint across the state of Wisconsin as healthcare systems, bringing more patients into the system, expanding the insurance network. And it really wasn't based on the residency at all. Our residency is actually the Gundersen Foundation General Surgery Residency Program. So even though the healthcare system will now be Amplify, the residency will still retain the Gundersen name because we are funded by the Gundersen Foundation.
Okay, sounds great. And the second thing that I would say is, I think I've told you this, but I rank Gundersen number 1 for my training program on the match, but ended up matching at my number 2, which was Mayo Clinic rural surgery track. Mayo Clinic has, they're a specific, what is it, NMRP, or what's the acronym?
or ERAS.
Whatever. Yeah, it's a specific thing that you're applying
Right.
for general surgery at Mayo versus the other, whereas Gundersen would be just kind of all applying to the same program. I only applied to that rural surgery track at Mayo, did not apply to the regular
Right.
program at all. Find out later there's 300 applicants and I got the one spot. This is why, so if you're a medical student,
Yeah.
trust the match.
Mm-hmm.
Don't worry about it, because if you match somewhere, then you know that place wanted you too.
Correct.
But the thing about Gundersen is they often go really high on their match list. And what I was told sort of later, I mean, I kind of came late to the game as a third into fourth year medical student. It really helps to do a elective at the place where you're trying to go. I did not do an elective at Gundersen. I kind of wish I would have. I did come and do like a second look and did a few cases with like your vascular surgeon and some people up there. But what do you like? Should I be encouraging right now if there's a medical student listening and they want to go to Gundersen to do a fourth year? Are you guys already overwhelmed with applications for away rotations, or what do you think about that idea?
Luckily, I get to screen everyone that applies for the sub-internships. So I really do screen out people that at least they're telling me they want to be, number one, a general surgeon, broad spectrum general surgeon. They're not looking to become, some small subspecialist. So I look for that. And then I also look for, do they have some sort of connection to rural America? So it certainly doesn't have to be people just from the Midwest. But because we have limited sub-internship spots, I do select out those that really will be, in my mind, a great fit for our mission. But it is a highly competitive world out there. The last 3 years, this is my third season interviewing as the program director. We've had over 600 applicants. I interview only 40 out of those 600 plus. And then we match only 4 people. So it's a numbers game. In the last 2 years, we matched our 4 people out of our top 10 candidates.
That's crazy.
I think it does help. But when I'm thinking about last year's class, only one of them did a sub-internship there. So it certainly is possible to match with us. It all, again, just depends on how much do I see them as the right fit. But it is, regardless, I just did my rank list this week. And I would say that I'd say everyone that we interviewed really fits what we're training. So I think we're getting better and better about, and I feel terrible that we won't match people probably above the 10 spot because they're all great. I wish I could train all of them. And as you know, it's a financial game too, as far as how many people we can train at each site. So.
Well, they'll all find spots. I mean, residency is one of those things where it's you get out of it what you put into it, for sure. Mm-hmm. And you can become a great surgeon at a lot of different places. I mean, you can go to Caribbean Medical School and become an excellent doctor, for example. Absolutely. Some of the best doctors I know, they took some sort of a track like that and then they owned it. And there's other people that like went to the beach, and partied and dropped out. Right. And so it's once you get in that door, it's what you make of it.
And Randy, one other comment on rural tracks, because Mayo's got the rural track. I believe they're still just matching 1, but I've heard rumors that maybe they would increase that. And UW-Madison also has a rural track, and they just increased from 1 to 2 spots. So what really encourages me, especially from my role with North American Rural Surgical Society, is seeing that many, many programs are beginning to realize, because again, oftentimes programs are run by academics, researchers, subspecialists, who have been focused on the training of the general surgeon. But I really think, I think we're the cool kids on the block right now. I believe this is a great time to be focusing on general and rural surgery. And again, I think we're seeing that even with our society, in that more and more residency programs that would have been considered more urban training programs are now realizing the benefit to training people for general surgery. So
yeah, great. Yeah, Madison was my number 3, of course. So I interviewed at 3 places that had a rural track, and it was those Gundersen, Mayo, and Madison. And I had no connection to that like I-90 corridor before that. I was like, down in Indiana, but then it's just ironic how I ranked a 1, 2, 3 like that. But beautiful section of the world, and now I have Gundersen privileges actually still, and I'm sort of like in your group in this locums role a little bit. So it gives me a little bit of people like to be connected still to their residency program. I like to be connected to the Cooley region of the world with those beautiful bluffs and go up there a few times in the summer. It's awesome. So Why don't we move on to the How I Do It section of the show? We're going to be talking about sentinel lymph node biopsy as it pertains mostly to breast cancer, the associated nuances, and rolling out a program in a rural place. So let's talk about first just who the candidates are for sentinel lymph node biopsy and getting a patient to the operating room, and then we'll talk about the technical details.
Perfect. Yes. So a big part of my practice is doing sentinel lymph node biopsies and mostly doing cancer surgeries. So I do it primarily for both breast and melanoma, but we'll focus on breast for today because there's extensive nuances to all of that. I have gone through the process of rolling it out with one of my partners who provides care on an outreach basis in Hillsboro, Wisconsin, which is very rural. So I helped him get a program up and running to add more breast cancer care out there. I also brought breast cancer care to the Sioux Falls VA when I was there. And so I'm happy to talk too about how to bring in sort of a new technology or new surgical procedures to an environment that maybe isn't used to having those. Who needs sentinel lymph node biopsy for breast cancer? Well, currently we still do recommend those for all patients with invasive breast cancer. We'll talk a little bit later in the segment about newer trials, which may be leaning away from doing them in many T1 patients. But for the sake of this beginning conversation, we'll just say if a patient has invasive breast cancer, at least for the last few decades, sentinel lymph node biopsy was indicated. It is not indicated for patients with DCIS unless you're doing a mastectomy. And we can even talk about nuances of that. But for now, again, if you have a patient wanting mastectomy with DCIS, we typically will do the sentinel node biopsy because if you find any invasive cancer during that mastectomy, for the most part, it's very difficult to go back and do a sentinel node.
Right. So if somebody has, I'm going to sidebar for just a quick second. Yep. Somebody has DCIS, they're going for mastectomy. What level of risk would you consider and discuss and potentially offer a contralateral prophylactic mastectomy for a patient versus like encourage them to do it? Like in terms of a percent risk, like is it 20, 40, you encourage, just throwing out some numbers, but you tell me.
Yes. When I'm counseling someone, and again, let's say they've already said, hey, I want a mastectomy for and you want me to specifically discuss DCIS for mastectomy or invasive?
Sure. You're doing a mastectomy on one side for either DCIS or invasive cancer.
Okay.
The reason that, first off, back to the sentinel node thing, the reason you're doing a sentinel node if you're doing a mastectomy for DCIS is because there's a significant upstage risk, correct?
Correct. Yeah.
Okay. So it's either reason you're doing a mastectomy on the one side. Now, the conversation about prophylactic contralateral mastectomy, I just kind of want to know how that goes and if there's numbers that you can share with our audience of like where like if their contralateral risk is 9% lifetime, do you steer them away from it? Just tell me a few thoughts about that.
Absolutely. If I'm offering them a unilateral mastectomy, I would, as long as they're an appropriate surgical candidate for a longer procedure, I would offer the possibility of a contralateral mastectomy to all of them. Let's say it's a patient with BRCA or PALB2 or some genetic variant that increases their risk significantly on the other side, then I would counsel them to have the contralateral mastectomy. That would be my recommendation. So if they have, and included in that group would be, let's say they have LCIS, because we can see up to 40 to 50% risk for both sides. Again, it depends. There's so many factors, including family history. But for things like LCIS, BRCA, PALB2, I really would recommend that they consider doing both sides at the same time. Because all of those groups, we can also offer bilateral prophylactic mastectomies to those patients. So even if they don't have a cancer, it's appropriate to offer bilateral to those patients. But if they just have cancer on the one side, their screening on the other side is completely negative, I still will offer the possibility of both sides if they want. So I offer that to every single patient, again, as long as they can tolerate that degree of surgery. And then I also offer up the possibility of breast reconstruction for anybody that's having either unilateral or bilateral.
Yeah. And so tell me, why do you offer the other side? Is it for symmetry, or is it for risk reduction, or what's the reason?
Mostly if they desire it, I give it as a choice of, all right, here's what, and I go through, here's what it would be like if we do a unilateral. This is how many hours you'll be under anesthesia. This is what it will look like when we get done. Also offer them the possibility of reconstruction or just wearing a prosthesis if they do one side. So I really try to lay out absolutely everything. And then I just say, again, if they're not in that high risk population, I say it is completely patient choice. It is not necessary to take the other side. And if we don't take it, you're going to get a mammogram every year. But if they're not in that high risk group, I really just say it's their lifetime risk. And I can put in numbers for them too. I mean, you can even use something as simple as the Gale model and just say, all right, here's your risk on the other side.
Mm-hmm. You like the Gale or the Tyler-Kruzak model?
We have just started switching over. We were using Gale model, and now our high-risk clinic is using the Tyler-Kruzak. In fact, they're now doing that on all of our patients coming for screening mammography. So patients actually have that. So every single patient that gets a screening mammo now has that number on their sheet.
I love it because it comes on the report, and then I don't have to actually plug a lot of stuff in. I just use it. But so I was talking to one of my colleagues that trained with me at Mayo, and she went to breast fellowship. Now she's practicing in Arizona. And my question to her, because I had somebody coming to me just asking for prophylactic mastectomy. She didn't have cancer. She was asking for prophylactic bilateral mastectomy. Busy mother. She was recommended every 6 months MRI and mammogram indefinitely.
And what was her risk? What was her calculated lifetime risk? Do you know?
I think her risk was around 20%.
That's usually the cutoff for insurance companies.
So like you're gonna encourage them over 20%. That was my question to her. Is like, if there's she said she would encourage somebody over 40% risk to have a prophylactic mastectomy, even like patient that doesn't have any cancer, both sides do a mastectomy. But if it's like 20 to 40, reasonable to do. Under 20, counsel them away from it. Do you agree with those numbers?
I do. When we refer someone to our high-risk breast surveillance clinic, which could come out of their, when they calculate their Tyler-Kruzak, or let's say they had ADH or some other high-risk lesion at some point, we outline everything that can be offered for them, from increased surveillance, maybe with adding an breast MRI, to the possibility of doing endocrine therapy, all the way to the possibility of doing bilateral. And have I had patients opt for bilateral prophylactic at above 20%? I have. I certainly don't push for that. That, to me, seems, if you look at baseline risk of being 1 in 8 women will get breast cancer, that's 12%. 20% is not a whole lot higher. I would say for most of my patients, 50% for them mentally seems to be a major cutoff. If you give somebody a greater than 50, that's a flip of a coin. Once they get above 50, almost everybody will opt for the prophylactic surgery. But have I seen people opt for it right at like 20.2%? I have. I don't encourage that. But it is approved. It's approved by insurance.
It's helpful for me to tell the patient, well, you got an 80% chance you're not going to get breast cancer your whole life.
Correct. Yep.
I
see that rarely, but I do have patients. In fact, I had one of my partners who is a breast fellowship trained surgeon. She just had someone who is 21 years old who's just hovering around that 20% say, I want both of them off at age 21.
Yeah, that's kind of how this situation was.
Yeah.
The main thing for this lady wasn't like, honestly, being too scared of doing breast cancer. It was like, I don't want to do every 6 months.
Right.
I don't have the time and the energy and the resources to do all this. And I would rather just do surgery now. If the choice is between those two things, it's not actually like I'm worried about getting breast cancer thing. So that was a weird conversation to have as well.
And especially if they have to drive, if you think about somebody that needs mammo and MRI every 6 months, and let's say they live 2 hours away from the nearest place, especially breast MRI, those patients, and let's say they're a farmer, right? And they don't want to take the time off. They'd rather just be done with it. And so that it is definitely acceptable to offer all those options. But at 20%, I agree with you, where you just say you have an 80% chance that you never get it.
Right. Okay, I have one more question before we get into the technical part of sentinel lymph node biopsy that pertains to what we were just talking about.
Mhm.
So your colleague that's in Hillsborough,
Mhm.
they are doing full spectrum breast practice there?
He does not have the ability to offer breast reconstruction. We do not have any plastic surgeons. So for patients that want reconstruction, he would refer them to Gundersen for that kid.
Yeah.
But he is able to offer sentinel lymph node biopsy. There's a lot of logistics with that because we use at Gundersen Crosse, we use the NEA probe. So those patients that go out to Hillsborough, they're getting their radioactive seed placed at Gundersen Crosse, which can be placed up to 2 weeks before surgery. So that can be done well ahead of time. At Gundersen, we do something relatively unique. I was not doing it back in South Dakota, but we inject in South Dakota, all our patients went to Nuke Med for formal lymphoscintigraphy before we did sentinel nodes. Gundersen did not do that. We inject our own lymphoseek in the pre-op holding area. So we go through a short training with Nuke Med. So he can bring lymphoseek out to Hillsborough, do his own injection because he's already verified to do that. And frankly, our lymphoseek actually comes from UW-Madison. So on any given day when we're doing sentinel node biopsies at Gundersen, it's arriving at 6:40 a.m. So we already are shipping in our lymphoseek. So that can be done really to any facility. So the lymphoseek arrives. All you have to do is be certified to inject it. So that doesn't really hold much up. It's easy to get that certification. And then, but he's got the NEA probe out there. So your hospital, no matter what you're using, let's say you're using MagTrace or lymphoseek, or you want to use ICG, you've got to have the equipment then to find those nodes. So that it has to be, what does your hospital want to invest in? We have the NEA probe already at Gundersen. So he was able to arrange to just have a NEA probe be out there when he's scheduled, cases are always elective. But that brings up another point for many rural surgeons. A lot of rural surgeons now are getting a robot. So many more are having ICG capability. So if you have ICG capability, you really probably don't need the lymphoseek. You could do blue dye and ICG.
I don't know. I've seen some patients back that had that somewhere else and they didn't catch the nodes.
Right.
So,
and I'm not saying ICG is better. We're still doing lymphoseek. I certainly think that 2 tracers are better than 1. I would not rely on just blue dye. I just did a case yesterday. The blue dye, injected it, looked like it was moving nicely. I had 0 blue channels and I had 0 blue lymph nodes. And it was my lymphoseek that picked it up. So, in the days now where we really are trying to minimize lymph node surgery, I really think you've got to have 2 methods to do it so that you're not doing full node dissections.
Yeah. So at the big house, we'll say, in La Crosse, Wisconsin, main Gundersen Hospital, where you're practicing, if the patient wants recon, then they'll meet with the plastic surgeon and you have the plastic surgeons on staff and you do a combined case?
Typically, yes, unless there's something about the patient that they want to do delayed, but that would be a decision made by plastics. But I would say most people getting getting reconstruction, most of them are getting it in the primary setting. I'd say maybe 10% are getting delayed.
Yeah, because I have a desire, and I think it's a great thing for breast surgery to be able to be done in the rural hospitals. I'm now in 4 critical access hospitals. All have totally different arrangements. Some of them have different types of probes and then some of them have Nuke Med and some don't. Right. And that can come and go based on even tech availability. So there's lots of crazy things. I don't have any plastic surgeons with me at any place, but what I was wanting to do at some point, hopefully sooner than later, is find somebody that would be willing to come in and help me. But that's really hard to do. And then do like the combined cases. I don't know if there would be a way to line up some other skin stuff and whatever for a plastic surgeon to come in and maybe have a full day, have other things to do while I was doing my part of the case. These are the things that I haven't got there yet with my own practice. And so then I end up having these conversations. And I've also heard of some people, especially in the Dakotas, I've heard of this. First off, you could place a tissue expander if you had a relationship with a plastic surgeon that was willing to do that. I have not found anybody in Indiana that wants to do that with me. The other one is leave the skin and just kind of stitch it up like a little volcano and then send them for plastics afterwards.
You can absolutely do that. I have done that even at the big house. Again, that's in a patient whereby they had already decided, but you could make that decision anyway, again, based on availability, where the patient's a good candidate for skin nipple areola sparing surgery, whereby you can do the entire case there, you put a drain in, and 3 months later, they go down the road and they get their reconstruction. So
you close the skin completely up.
Yep.
At your incision.
Mm-hmm.
You don't like do a purse string stitch and leave it a little bit open, do you?
Nope.
No. Okay. That's some ways managed like a colostomy site, you know?
Yeah, it works fine because our plastic surgeons primarily are doing sub-pec implant, sub-pec expanders, tissue expanders and implants. So there have been times that they've decided to do that anyway. For instance, I've had some patients who are extraordinarily thin, so they don't have much of a fatty layer behind the skin. And so they don't want to stress it at all initially. So I'll do the skin nipple areola sparing mastectomy, put the drain in, plastics follows up with them, and then they wait and they let that flap basically sort of breathe. And then they put the expander in down the road. So the results look beautiful. So there's no reason why you can't do a multi-stage procedure.
Including mastectomy, right?
Mm-hmm.
And that's why I'm saying, how can we do the mastectomy in the rural environment? That's what I was asking about Hillsborough, but Great answers. The LymphoSeek trade name, so that is Tech 99, correct? Yep. Okay, so is that the same stuff that's being injected in nuke med when they're doing the scintigraphy? It's the exact same stuff, right?
Same stuff. We just don't do the imaging. We do for melanoma, so don't take this to mean because melanoma, especially melanoma of the trunk, can cross over, it can go up to the neck, it can go multiple places. So for our melanoma patients, they still get formal nuke med lymphoscintigraphy with imaging. For breast, we do 0 imaging. We do the injection literally in the pre-op holding area, and that patient rolls back to the OR. We inject the blue dye in the operating room, and we go ahead and do it. And I listen, and I already have uptake in the axilla. By the time they've rolled from pre-op to intra-op, I already have LymphoSeek uptake out there. So
yeah, I think that would make me comfortable if I heard counts in the armpit, but it really gives me a lot of peace of mind to see the picture too, even in a breast case. I did see a case in residency that was a re-op, and that one tracked to the internal mammary nodes. But that would be a specific thing. Maybe you would still get imaging on something like that to track it down. But
re-ops, I send a nuke med and I have to get imaging. And I have to admit, and again, I don't know that you'll find a protocol for this, but I have even done, let's say your patient has a bilateral mastectomy with reconstruction, and 5 to 10 years down the road, they get a local recurrence, like along the skin incision. I do send those patients to nuke med because by then, especially if a lot of time has passed, they have already established new lymphatic channels and networks. So those patients, I get them injected, but I do it in nuke med because you're right. They could go to internal mammary. I've even seen them go across the chest, but then I do a repeat sentinel lymph node biopsy. And we're talking about people that have really no breast tissue left, but they have a skin level recurrence. So I treat it almost more like a melanoma as far as that protocol.
Yeah, great. And our listener may find themselves in a rural place where they don't have those nuke med capabilities. So that would be a patient that you then have to send
that patient out. Yep. But
that's the problem is
I can do with LymphoSeek injection myself with no imaging.
Yeah. But the problem is there becomes so many patients that then you're sending out because of the plastics thing or because of the nuke med thing or one reason or another. And then, there's only so many cases to begin with. And now you're cutting the volume in whatever, half or, down by a third or something. And so then it's even further sort of out of your hands. And I think that for a rural surgeon, it can become one of those things where you just say, like, I don't do that. The problem is breast is the best case to do from a anesthesia risk perspective. It's not cavitary surgery. You're never going to need an ICU for the most part for these patients. It's skin and subcutaneous tissue. A lot of it's going home the same day. It's like the exact type of surgery, a short, simple case with low morbidity mortality that we want to be doing. But then because of this, if we lose it, that's why we're having the conversation. What can we do to keep it close to home? But
Number one, I think the surgeon has to want to do it. And then you've got to be willing to get by some of those obstacles. Like you've got to have multidisciplinary discussions about these patients. And you think, well, how can I do that? when I was at the VA, even though I was located in Sioux Falls, we didn't have all the players to have a multidisciplinary conference. So I reached out to our 2 private hospitals and said, hey, I want to present my patients, albeit virtually, at your multidisciplinary conferences. So I could still, not just to check the box, but that really is the best way to care for them. But immediately, it just happened to be Sanford that said, hey, we'd love it if you did that. And again, you can scrub patients' names so there's not HIPAA issues, but you can do that in the world of virtual care. You can check that box. You can figure out 2 ways to do Sentinel lymph nodes. You can try to recruit a plastic surgeon to come out maybe twice a month. That's possible. I did recruit a plastic surgeon to come over to the VA just to do breast reconstructions. He was an older, nearly retired guy, but he said, hey, I'd love to do that. So it's possible. You've got to know the people and go after them, but you can also do delayed reconstruction. So that's possible. There's many, many ways to sort of get around, but there will be roadblocks thrown in your way. So you have to want to do it. And you can run your own high-risk surveillance clinic too. You really can. And patients absolutely love it. They want to stay rural. So it's possible to do, but you've got to, I think, let's say you trained wherever you trained, I think you have to go with that mindset to whatever hospital you set up shop and say, I realize you haven't been doing breast care. Here's the pieces we need to build. And it is possible to build almost all of those pieces. Again, you're right. You're going to have to send out certain patients that just can't stay there. But I would say over 75% of the people that I operate on regularly for breast, I could easily do at a critical access hospital if I built in these pieces. So it takes it just takes the passion to do it, I feel like.
Everything you say triggers me for like 3-4 questions, right? So we could go all day. Yes. But there is one that I want to touch on because a buddy of mine this week asked me about, do you have a tumor board that you could present your cases at? And the answer is kind of yes, but I haven't done it. But the other thing that I ran into, this was like a couple years ago, so my memory's a little fuzzy on how this went, but the way I remember it happening is I approached a system nearby, and now I'm more like tied in with a few other systems, so I think I have more options. Yeah. But at that time, what I remember them saying was, we would be happy for you to present your own cases, but we would not welcome you to attend our tumor board. You could come in, present your case, and then go away. And I don't feel comfortable with that, because what I want to do actually is just like attend their tumor board for like 4 to 6 months, and get comfortable with how they talk about things, so that when I come in, I don't look like an idiot, because I'm presenting it whatever the way I would normally present it. I want to kind of like fit into their system, and that wasn't cool. So I just like said no. But did you experience that with Sanford?
I would look for a different system. Yeah, because Sanford was very willing. Again, I also had privileges at Sanford, but again, this was me bringing in outside cases. And at the time I was clinically 100% at my elective practice was 100% at the VA. And they said, absolutely. And I was allowed to attend their tumor board, and I could pipe up about their cases. They gave me input on mine. But I have to tell you, the other system that I approached with it wanted nothing to do with it. So you've got to find a system that is open and willing, and it should be. I
just want to sit in on like, at least a half a dozen tumor boards before I like open my big mouth and say something, it's just a little intimidating. I mean, if it's intimidating for me, I'm sure it's intimidating because I got too much extroversion to begin with. So for most people, I can imagine it would be intimidating anyway. So tell me
up on CMEs though too, right? Because it makes it easy for you to get CMEs at your rural hospital. But we offer CMEs for our breast tumor conference, which we have every single week at Gundersen. So it's a great way, again, for you as the rural surgeon to stay up to date on everything related to breast care, and to earn CMEs at the same time.
Well, I have Gundersen privileges. Maybe I should look into the Gundersen breast thing. That's not even in my state. This conversation was so good and packed with information that I had to split it in two. And trust me, you're not going to want to miss the second part. So join me next week for more with Mel Johnson on the Rural American Surgeon.